Well, good day. My name is Laszlo Mechtler. I'm a professor of neurology and oncology and medical director of the Den Institute and also director of the Den Cannabis Clinic. We've had these meetings before on Facebook, and apparently the information that I share with you all has been positive, and individuals in this Facebook Live or YouTube can ask me any questions during the course of this 1 hour discussion. In this meeting, I'm going to update you on what's going on in cannabis, which I think is rather exciting. Things are changing, and for once, they may be changing to a positive way. I also would like to probably introduce you to some of my research team and discuss what we're doing here at the Den Institute. For many who don't know, the Den Neurologic Institute is the largest neurological institute in the United States. We do see close to 1,100 patients on a daily basis. We see about 115 cannabis patients on a daily basis. We have an infrastructure supporting that in our Den Cannabis Clinic, and we have over 30 individuals seeing patients for various reasons for the use of cannabis in the treatment of not just pain. So I guess what I should start off with is it's getting a little bit confusing out there because now, since the Farm Act of 2018 that was signed by the president in December, we now have this hemp-based CBD products out there nationally. So let me just start off. Then we talk about cannabis, and as you know, I like to use the term cannabis instead of marijuana because the marijuana is actually a derogatory term that came out of the 1930s, and the proper term has been cannabis through history, and the plant is actually the cannabis sativa or the cannabis ruderalis or indica. These are the three main plants. So in our cannabis clinic, when we talk about cannabis, there's really three types of cannabis. One type is the recreational, and the recreational cannabis is what you hear about smoking. It's what 10 states in the United States have already legalized, which is adult or recreational cannabis. I don't deal with that. It's hard for me to support recreational cannabis when individuals have to smoke it. At the end of the day, I'm a physician, and for me to promote smoking when I've been anti-smoking for my whole career would be very difficult. So I'm not going to talk about recreational cannabis. And by the way, recreational adult cannabis is mostly high THC and low CBD. You have to realize that. So when people compare recreational to medical, there's a huge difference because recreational marijuana is high THC, low CBD, because naturally the plant doesn't produce a lot of CBD in the plant. I know there's some exceptions to that rule, but the higher the CBD content in a natural plant, most likely more expensive the product is. Then we talk about medical marijuana. Medical marijuana has been legalized in 33 states in the United States, including New York State, where we reside. Medical marijuana allows the physician to change the ratio. Yes, you can have a 20-to-1 ratio of THC to CBD, but you can also have a 1-to-20 ratio, meaning the CBD overwhelms the THC, and you can have a 1-to-1 ratio and everything in between. What medical marijuana, which is a state-run programs and legalized, as I mentioned, in 33 states, it allows physicians to give for specific medical disorders, many of which are neurological, such as MS, ALS, neuropathy, spinal cord injury, epilepsy, chronic pain, HIV, and neuropathy. And I've mentioned most of them, not all of them. And in New York State, they added chronic pain and substance abuse and opioid use. So with these indications, we can now look at a patient at our cannabis clinic. And just so you understand how many patients we see here, this is the number. This is the pie chart. So what this shows is that most of our patients come here with the purple for pain, but other disorders also happen. So right now, this is the amount of patients we have. This is information that I only share at national meetings. There we are. Okay. As you can see, we have over 8,700 patients that we've seen at the Dent Cannabis Clinic, of which most of them are chronic pain. These numbers are quite large. We see close to 10% of all patients in New York State. So we have a large amount of patients that we see. But most importantly, I have a very strong research team where every patient that comes to us fills out information that we download in their medical records. So then we can retrospectively ask questions and try to answer them based on a large population of patients. So I mentioned to you that there's three types of cannabis. The one was a recreational adult. The second one was medical marijuana, which is a legalized program in 33 states, as I've said. And the third is hemp-based products. Now, hemp is actually the byproduct or is the product of cannabis sativa. So it comes from the same plant. The difference between hemp and, say, recreational marijuana is that in hemp, you have less than 0.3% marijuana. So that number is very important. Once it's above that, first of all, it's not legal to sell in stores. It has to be less than 0.3%. So it's very low THC and high CBD. And people who are looking for CBD are looking for its health benefits. The four main health benefits for CBD is it's a anti-inflammatory, like ibuprofen without the stomach problems. It is a painkiller without the problems of opioids, such as addiction. It is an anxiety medication without the side effects of benzodiazepines like Valium or clonazepam. And it helps you sleep without the side effects of Ambien. So here I have a drug that's natural with minimal side effects. I'm talking about CBD that helps you sleep, helps anxiety, helps pain, and helps inflammation. Now, let's be fair. That's a drug that could help anybody, especially as you're getting older. So the third cannabis is hemp-based, full spectrum or isolate CBD products. And that's what you see everywhere in the stores, sometimes in where you work out, sometimes where you have waxing or pedicure or manicure. There's one problem with that, and you need to know that. The problem is really simple, is that it's not regulated. And please remember that. And the reason that's important is that there is information out there, and here's an article that I'll show you. The guy is he's actually from Netherlands, and his name is Arno Hazenkamp. And Arno Hazenkamp did a study where he looked at 46. You heard he went on the internet, got 46 CBD products, and reviewed them. And in his review of 46 products, so he bought them, got them off the internet. It said CBD on them, CBD oil. And he checked them. He checked them actually for what was the CBD content. And you have to understand that the CBD content was actually zero in 39% of this 46 samples he bought on the internet. So what that tells us, there's a good 39 to 40% chance you're not getting any CBD. The other problem is that the THC level in those products were extremely high. Some of them were 57% THC. That should not be legal, but if it's not regulated, it really doesn't matter, does it? So you have to be very careful in what you do, because unregulated CBD needs to be third-party tested. What does that mean? Well, when you buy a CBD product anywhere, there should be a QR code on it. What's a QR code? Let me show you. This product here, I brought one for you. Right here. That's no, right there. Okay, that's a QR code. As you can get an app and download the information. And that information should come from a third party. And here's an example. So when you look at the QR code or you get the third party testing, this will give you information on what's in the product you just bought that is not FDA regulated. Now, there's two things you have to look for. One is, what's the actual CBD content? What's the THC content? That's very important. So you have to know that if it says 10 milligrams of CBD, that you're actually getting that. So please look at the third-party testing on every product. In all fairness, most products don't have third-party testing because that would make the product very expensive, which it does. So you're looking for the actual dose of CBD. You're looking for the fact that it should not have a lot of THC in it. Then you're looking for what we call contaminants. Ethan Russo, a famous botanist, looked at products and noted that approximately 70–80% of patients who are getting their CBD products and marijuana have contaminants, such as heavy metals, insecticides, pesticides, and fungus. And it's not fun if you take a lot of this and there's byproducts in there that were not tested. So some of the third-party testing will test for THC, CBD levels, maybe even terpenes, but many of them don't test for contaminants. So please, as a consumer, you need to be understanding that what you're buying out there is not regulated by the government. Now, having said that, we've been doing research at the Dent here for the last 3-4 years. We've received support from a company that's called Jushi, which is a sushi with a J, and this is not a plug, but this is actually factual. And their products were formulated by us here at the Dent, and we call those products men products. And the reason that's important, these are third-party tested for contaminants and actual dosages of CBD and THC. The men products are different. Right now we have soft gels and we have lotion and we have tincture. Tincture being a eye drop in the mouth, which I actually like to use a lot. So these are pure CBD products under the heading of MEND. That MEND product is actually being now will be sold in the near future in California, Pennsylvania, Nevada, around the country, and it's physician formulated. It's based on our research, and we have done extensive amount of research here. So let me move on to say that recently, in the last few weeks, there's been new legislation brought on by Senator Harris and Nadler being from New York, and it's called the MORE Act, M-O-R-E Act. This is an act, federal, that they would like to change the federal law to take cannabis or marijuana off the Controlled Substance Act, which is Category 1, and in this way allow us researchers in cannabis to see more patients and do research without the issues that we have with the federal government, which is quite a lot. So I'm very optimistic. They say that maybe by the end of this year, they'll be passing the MORE Act, and we'll be able to do research in the treatment of patients with medical marijuana. Now, having said that, I'm going to now introduce you to 3 individuals who are helping me do research. And these individuals are young college students who want to go to medical school. And I'm proud to say that 2 of them have, and I've just been accepted to medical school. But without them, we could not do the research. Now, you have to ask the question, who pays for this research? Pharmaceutical companies don't. The government does not. So actually, we actually use these students and pay these students to do research based on money that we bring into the Dent, and also recently this company, Jushi, is paying for one of the pay lines for one of the young men who have done research. So I'm going to introduce Paul Hart. Paul, why don't you come over here and get behind me? And I choose you because he's done great work for us, published a lot of articles, presented them at international and national meetings, and is now going to medical school starting in September. So I'll be losing this fine young man. So I'm going to ask him to present something that he did here. Paul.
Hey, my name is Paul Hart. I've been fortunate to work for Dr. Mechtler for the last year in research cannabis and Dent. One of the unique things about Dent is that we're such a large institute that we were kind of in a unique position to start doing a lot of retrospective research with very large sample sizes. And right now, unfortunately, because of the way that legislation works in the US, as Dr. Mechtler has explained, it's very difficult to do prospective research. So the gold standard right now is retrospective research in a clinical setting. One of the things that has been difficult to really do is educate providers on what to give patients because we just don't have that information. Dosage, safety, the things that you typically have with a pharmaceutical medication, we don't have yet with cannabis. So what we've been trying to do is create a database and look at different patient populations to see what works and what doesn't work, what's safe and what's not safe. So one of the things that we looked at this past year was in elderly populations, how well or how poorly does cannabis affect those patients? What dosages do we need to do for those patients for them to have the most efficacy while having the least amount of side effects? We were lucky because we were able to present this research at the AAN in October, and thank you. It was selected for press release out of just a few abstracts, and that means that the AAN saw our research, thought that it was beneficial enough and novel enough to promote the event at the American Academy of Neurology for their annual 71st meeting. So we found basically that, in an average population age of about 81 years, so these are people that are typically going to have a lot of different conditions, different chronic conditions, and they're going to probably be on a certain number of medications, right? So they may have side effects from those medications. They may have a lot of interactions from taking so many medications. So if they can switch to cannabis as an alternative, it should have fewer side effects. We found that only 30% of patients actually had side effects, and of that, half of them resolved with a change in dose or change in time, which if you're talking about a pharmaceutical medication, is actually really, really great. And if we can get those patients off of opioids, which a significant percentage of them did, almost half, that's also significant. As you know, with the opioid crisis going on, we're looking for any alternatives we can get to addictive substances that also have serious side effects. So we have a long way to go with this research, but right now the unique opportunity provided at Dent with our large patient number, and unfortunately with the obstacles that we have in legislation right now, this is really the best type of research that we can do. So we're very fortunate to have the funding we do from the Dent Family Foundation, and leadership from Dr. Mechtler and his team at the Cannabis Clinic here to allow this research to happen. So I think with that, I'll turn it to one of our other research assistants, Vincent Vargas, and hopefully.
So this is a young man that did research for us, and now he's moving on to become a physician. And we know that with his knowledge of cannabis and research, he'll be an advocate for many years. As I've mentioned in the past, when I personally started in cannabis, I was purely a skeptic, and I've changed my tune since that time, where I'm a strong advocate. So Vincent Barnes also started with us about a couple of years ago to do research. Vince was accepted to medical school, and now he finished his first year of medical school. So we're very proud of him. He's going to talk a little bit about what he's done with us.
Good afternoon, everyone. Again, my name is Vince Barnes. Nice to all see you on here, and I'm so glad there's such interest in this incredible and novel field, especially in the setting of neurology. Just a couple words here. So one of our other studies was on chronic migraine. Chronic migraine is a really debilitating disease that really affects millions of Americans. So we took about 316 patients here at the Dent Neurologic Institute who incorporated medical cannabis into a chronic migraine treatment plan. And we looked at both quantitative numbers that we can find off of patients, but also qualitative too. So chronic migraine, like I said before, is really a debilitating disease, and obviously that manifests in headaches and migraines, but it also affects patients in holistic approaches such as anxiety, sleep disturbances, mood disturbances. So we took a look at both what numbers we can pull from how cannabis has been affecting these patients, but also the non-numbers things, the how it makes them feel. So very briefly, some of the big highlight numbers is we saw improvement in 88% of our patients, which is really we can't ignore that. We must report that outside of our four walls of our clinic. But also we saw a decrease in monthly headache days. Monthly headache days went from 24 days to about 17. That is pretty significant. It was significant in our statistical findings, but also too from a patient-physician relation standpoint too. That's an incredible improvement. That is really a remarkable and a positive improvement. We also found about 56% of patients who were on opioids reduced their opioids. Another number that we really like to see, less opioids in our patients. And like I said before, we also found improvements in anxiety and mood and sleep. And it was very, very well tolerated with very minimal side effects. So I'm incredibly excited to see this, and I encourage other works to come out, and incredibly blessed to work with Dr. Mechtler in providing these patients with a promising treatment. Thank you all for your time. And I think we're going to go head back to Dr. Mechtler for some more research updates.
It's pretty bad when your student looks smarter and speaks smarter than you do. So you were using words I couldn't pronounce. Anyway, so let me just tell you a secret. So we had this article about chronic migraines, and we wanted it published. So I called the 4 top headache specialists in the world to review it. And each one came back on the email and said, it's wonderful. Some of them used the term dramatic findings that we found needs to be published. Everyone said that. So 3 days ago, we presented it to a journal, which I won't name. And within 12 hours, they sent it back and said, no, not good. So we said, okay. Then we sent it to another journal. And within 24 hours, we got the response. They will not publish it. This is the problems we have in cannabis research. Not only is it the fact that the federal government gives us a difficulty using cannabis in research on human beings, even though it's been used for 12,000 years, but also the establishment of medicine is resistant to the science that we're producing here, which is very unfortunate. Now, trust me, we are not giving up. We are moving forward. We'll just find a journal that will publish our findings, and then you'll be able to read about it. But I do feel that this study that Vince mentioned has strong ramifications in the treatment of headaches in our population. So the third research is the newest one, who has joined me a little bit over 6 months ago. I want to introduce you to Chris Rayleigh. He's going to talk to you about our newest study that we're doing. And again, we have about 8, 9 studies that we're actively looking at. And I want Chris to just summarize what he's been doing.
Hi, everybody. My name is Chris Rayleigh. Dr. Mechtler just said, following up with Vince and Paul. We're doing a lot of interesting research here at the Dent. And one of the issues that everybody keeps saying is, what is the cost of marijuana? And what we're seeing as part of our research, as a lot of people that's the number one sticking point, the cost of treatment. We see that the average cost of treatment is about $200 a month. And what we did is we're looking at underserved populations to get a better understanding of cost as a factor of their treatment plans. So we currently ran a study. We looked at 1,200 people at our cannabis clinic and looked to see what are the efficacies reporting, how are they doing with medical cannabis. What we found is that 80% of all people that used medical cannabis had some positive outcome as a cost of, from using the treatment. But what we also saw is that in the underserved populations, the ability to afford medical cannabis went down significantly. We had retention rates in what we so-called normal populations about 70%. In the underserved population, it was about a 50% retention rate, which means we're losing 50% of those people visit after visit. Now, we're also looking to present this research at an Nashville conference coming up, because once again, it is a hot button issue. Another thing we're looking for, and we're constantly looking for, is what is the opioid use? And are we able to reduce the opioids that our patients are using? And what we found is about 36% of all patients included in this study were able to reduce their use of opioids by using medical marijuana, even if it was at a lower dose than what we'd recommended here in our clinic from one of our, I believe it's now 36 providers, Dr. Mechtler?
Yeah.
36 providers that we have at the dent with our 100 patients that we see every day. So it's very, very important to see this kind of research come out with the idea that we can use this to frame an argument with some of the payers to help cover the cost of treatment for all you folks out there that are interested in pursuing medical cannabis as a treatment option.
Thank you, Chris.
As you can see, we have these fine individuals who have spent time doing research in a subject that has not been researched adequately over the last several decades. And although these young men are pioneers in many ways, it will establish them as individuals and physicians who are knowledgeable in the use of medical cannabis or marijuana going forward, and they will be teachers one day. So what I like to do at this point is introduce you to somebody that's been my right-hand person, my executive assistant, who really established the infrastructure for the cannabis clinic. So I'm going to introduce you to Amanda McFadden, who has been very important, and she's going to give you an update about our cannabis clinic and where we stand with that.
Hi everyone, I'm Amanda McFadden, and I run the administrative portion of this program. So as most of you know, and a lot of you have dealt with the wait times of the cannabis clinic, we have added more providers on, and we're excited to say that our wait times are extremely cut down. So right now we are accepting referrals, and I just wanted to tell you how you guys can go about getting into the clinic. So if you visit our website at www.dentinstitute.com, there's a cannabis clinic logo, and you can click on that, and your provider can fill out a referral form that looks like this. And once we receive that, we review it and we put you with the appropriate provider. As most of you know, we don't accept workman's comp older than 2 years, but we are excited that we do have a physician that is accepting workman's comp under 2 years, which is fairly new, and we're excited about that so we can help a lot more people with chronic pain. We don't accept self-pay. We do go through insurance. And if you have other questions, you can comment on that in the box, and we can try and answer as many as we can for that. Is there anything else you'd like me to touch on? In the men's store downstairs, we do have some third-party tested products that are not Mend brand, but we are excited to offer some gummies. We have salves. We have waters down there, and we have sleep aids and patches and all sorts of good stuff. So this is the water. We've had really good responses. Here's some gummies. These are about $15 a package. They're pretty cost effective, and they are selling out like hotcakes down there. So they're very excited to have them, and our patients are benefiting greatly.
Thank you, Amanda. So CBD products does not have THC. So individuals who may carry guns at home because you can't be in a medical cannabis program if you own guns, or you drive trucks, or you work at the VA system. CBD products are not psychoactive. They're pure CBD, meaning there's no THC of any significance. So you actually don't need a prescription for that. Now, if you're one of our patients, the advantage is you get 20% off in our store, which is in the Dent Tower, first floor. The problem with medical marijuana program we have in New York State is rigid, which I like because it allows physicians to control patient care. But it's costly. Why? We have third-party testing. Everything in the medical marijuana program is third-party testing. So we realized very fast in our research that a good 35% of patients do not go to the dispensary and get what we certify them for because they can't afford it. And that proportion of that 35%, the proportion of African Americans is much higher than Caucasians, which is really unfortunate because, as you know, historically, marijuana has indiscriminately affected the minority population more than the Caucasian when it comes to persecution, criminalization, and has affected those communities. So, I understand that perception, and that's why I think we will be publishing how to obtain medical marijuana for our patient population that needs it, that can afford it, because to be certified and then registered but unable to afford it is really a crying shame. And that's what's happening in New York State and many other states, is that I just saw a patient, this is the highest I've seen, was paying $1,300 a month for their medical marijuana. As my research assistants have said, that the average is about 200 some dollars. The real problem is when they get medical marijuana, they underdose themselves. They're supposed to be taking it 3 times a day. They take it at night. They take it every other day because they cannot afford it. And that is not the purpose of the use of medical marijuana. We're very proud that one of our research studies was reviewed and presented all over the world. That's the geriatric research that we did from 75 to 102. Yes, you heard it, 102. In fact, just the last 2 days, I saw a 98-year-old and a 94-year-old. And so age is not an issue here. And our publication showed that in that population, we don't see significant side effects. And so it's safe. And again, we don't see people getting high. Nobody comes to us because they want to abuse medical marijuana. Because if you want to abuse drugs, it's cheaper to abuse it on the street, which I don't recommend. So these are some of the issues and updates we have. So we are presenting our research at national and international meetings. I'll be lecturing out in California at one of these cannabis meetings with Ethan Russo and also with Mesholem, Raphael Mesholem, who is the founder, who founded, let's be honest, with THC in 1964 at 80 some years old. He'll be at that meeting. So there's a lot of exciting things going on. I'm very much looking for this legislation that may allow us to do prospective studies. I'm working with an insurance company in Western New York to do research with Albany together, the 3 of us, meaning the Albany, the state, an insurance company, a payer, and us to do research on what happens if you pay for medical marijuana. Is there a cost savings? I can tell you right now, some initial research has shown people who take medical marijuana save payers a significant amount of money on the use of other drugs. I have so many patients who threw away 4 or 5 medications since they've been on medical marijuana. So I feel that it would be cost effective for insurance companies to pay for medical marijuana so patients stop visiting emergency rooms, stop seeing doctors, have improved quality of life. You heard the numbers we had. 80% of the patients feel better. 80. Now, that number is, let's be fair, it's ridiculous in medicine. So we have something here. We know it's safe. We don't see people becoming addicted. People get addicted to nicotine and vapes. That's a real danger we have today. People get addicted to smoking. People get addicted to alcohol. The addiction rates for marijuana are exceedingly low, although there is a subpopulation that I am concerned about. That's adolescent, children growing up, teenagers who feel that they can do what adults can do. They can't. The brain still grows till you're 21 to 23. And if you smoke marijuana, it may affect the growth of the brain. Now, I don't believe CBD does that. It would be more of the THC. So we have to be cautious in adolescent, in patients who are pregnant, and also in women that are lactating. So there are subpopulations that we keep an eye on. But let's be fair, most of our population is adult, and they seem to be tolerating quite well. So I'm going to ask if there's any questions that need to be answered. Oh, here's some questions. So Julie, patient says she has epilepsy. Her doc says she has had the worst kind to get it. Doesn't understand why she can't take a plant versus pills. Probably she's seen at the den. Okay, so that's a good question. So the FDA has approved Epidiolex, which is a CBD isolate for the treatment of two types of epilepsy. One is called Dravet, and the other one is called Lennox-Gastaut. These are rare forms of epilepsy, and let's be honest, the worst type. These children, if you ever seen one, are having 100 seizures a day. And the study was done out of New York City by Davinsky at NYU Langone. He did the study, and the study showed that when giving high doses of Epidiolex, which is CBD isolate, the frequency of seizures decreased by 50 or 60%, which is dramatic. And some people, the seizures went away completely. We have patients in in Buffalo, who have dramatic responses with CBD. That drug, or Epidiolex, is owned by GW Pharmaceuticals out of England. And that's very expensive. It's, to my knowledge, it's over $30,000 a year. But remember, for you to use the plant, a CBD plant, not THC, because THC could make epilepsy worse. Hear what I said? THC, Julie, can make epilepsy worse. CBD. But the CBD used in that study was anywhere from 1,000 to 2,000 milligrams. Now, the CBD that you're buying is 10 milligrams, 20 milligrams, 30, maybe 50, not 1,000, not 2,000. So, and there's been no research that's shown that CBD helps epilepsy in adults, such as partial epilepsy or major motor convulsions or grand mal seizures. So that research has not been done. So that's why your epileptologist is not pushing CBD, because it's not the right type of epilepsy. And the drug is $30,000. If there's no science that proves it works, then you can't use it. But I do feel low dose CBD may be helpful, because it'll help you sleep, which decreases your seizure potential. It helps anxiety, which decreases your potential for hyperventilation and seizures. So I think low dose CBD may help. All right. Second question, May. Any progress with adding autism or Tourette's to indication lists? There are some states in the United States, and if I remember right, Louisiana, believe it or not, is one of them, has autism on their list. I don't see any movement in autism in New York State. So there's two issues of autism. Most of the time, when you use cannabis in autism, these are young children. And it begs the question, if you use THC, could THC affect the growth of the brain? And the answer is, we're not sure. There's some science that says yes. There's been science that has said no. So at this point, it's not indicated in New York State, but there's, you need to talk to our pediatric cannabis division. That's run by Dr. Jennifer McVig. She has ways to look at autistic individuals and see if they are candidates for medical marijuana, either high CBD or a 1-to-1 ratio. She feels, personal communication, because I don't see those patients, she feels that it does help her patients. So again, talk to our cannabis clinic, Amanda McFadden, and if you're interested in a consultation for autism, at least you can talk to Dr. McVig. Tourette's is similar to that issue. I have to tell you that Dr. McVig, who's a wonderful pediatric neurologist who also specializes in cannabis and has lectured at international meetings on this subject, including autism, recently in Philadelphia at the American Academy of Neurology. it is worthwhile getting her opinion on this subject. I think she would like to do a research study on this subject. Agnes, do you know when New York State is going to start having flowers? The answer is I don't know. As you know, there was a strong move to approve recreational marijuana. The problem with flowers, the problem with the anything that you grow at home is that it normally will have contaminants. The plant itself, Cannabis sativa, draws everything out of that soil, good and bad. So you have to watch out that whatever you do at home or with this flower, that it is third-party tested, and 99% of the time it's not. If you're a chronic user and you're taking insecticides, pesticides into your body, we would never do that with anything else. So why would we want to do that with cannabis? If we're going to be in the cannabis movement, let's give pure cannabis without insecticides, pesticides, heavy metals. I'll tell you a short story. I've mentioned this before. They say that marijuana or cannabis doesn't kill you. And in fact, over 12,000 years, there's never been a documented death from overdose of cannabis. Okay? Yes, you could have a paranoid psychosis if you're prone to that, especially with edibles. But I will tell you that I had one patient who was a brain tumor patient of mine, who was a wonderful young lady, age 28, who really was treated for a brain tumor that was stable. There was no evidence of growth. She was living her life, but she loved her bong. She loved to smoke her marijuana. And I told her, you shouldn't do that. Let me give you medical marijuana, which is third-party tested. But she loved her bong. She loved to smoke it. He came down with a lung lesion. The lung lesion was, I thought maybe it was a tumor at 28, and we biopsied. It turned out to be aspergillosis, which is a fungal infection that you can see in dirty marijuana and bongs, and she died of the lung disease. So I've lost one patient from marijuana, but not from medical marijuana, and not from the effects of marijuana, but the side effects of marijuana. Please remember that. If you're going to do it and you're going to buy it from friends and on the street, you're taking a chance from anything you're doing. It could be spiced and it could have contaminants in it. All right, this is another question. Oh, from Agnes. You're being busy. Is there a part that doesn't have you eat hungry? Yes. So, the joke in the movies is you get the munchies. That's THC. So THC is good for cancer patients who are losing weight. It's good for patients who have gastrointestinal problems and have chronic nausea and vomiting. In fact, THC was synthesized to make a drug called Marinol that we use for cancer patients. But that's a synthetic THC. Most people never loved it. But THC in itself will increase your appetite. Now, CBD, not many people know this. If you take CBD, there's a real potential. It's a weight loss drug. Now, the science and the proof of that is not there. But if you take enough CBD regularly, it will clean up your gastrointestinal side effects, especially in patients with irritable bowel syndrome, for example. And CBD will also potentially be able to cause you to lose weight. And the research needs to be done to prove that. So I don't want you to leave this discussion saying that Dr. Mechtler thinks that CBD is a weight loss drug. No, but there's some science that points to that direction. So if no further questions, then what I'll do is talk about some of our studies. Oh, this is the study I wanted to tell you about. Okay, right this way. Got it. Okay. Chronic migraine and treatment with medical cannabis. This is a study, and you see my students' names on there. This is a study that really, I think, may rock the foundation of individuals who are anti-cannabis, because this really showed that the most difficult population of pain, chronic migraineurs, defined by having more than 15 migraines a month, many of whom have 30 days of headache a month. This population got better significantly with the use of medical marijuana. That is something that is very encouraging. Once I'm able to publish that, people will point to this study to say, why is it Schedule 1? Why is it Schedule 1? Well, if you know the history, and I've said this before, Schedule 1 is something that happened in 1970. And it was called the Controlled Substance Act. If you know the history, read it. Or if you don't know the history, familiarize yourself with it, because it was really purely for political and racial reasons that President Nixon wanted cannabis or marijuana in Schedule 1. And Schedule 1 drugs include heroin, LSD, Quaaludes, ecstasy, and peyote, which is used in Native Americans and religious orders at times in the past. So that's Schedule 1. And the definition of Schedule 1 is no medical effect and highly addictive, both of which are just not true of medical marijuana. So other things we've looked at is we looked at this, we published this, American Academy of Neurology, and that is Parkinson's. And we've noticed that patients with Parkinson's disease at times have dramatic benefit from the use of medical marijuana. And once more, these patients don't get high. This is an article, and the lead investigator was Dr. Bennett Myers from our institute, because we're not the only ones. We have multiple physicians doing research. For example, in this study, was multiple sclerosis, MS. MS is, we know that medical marijuana has been proven to help stiffness or spasticity. And this study was with Kathleen McCormick and our MS group led by Dr. Mazzari. So this was an important study looking at 77 patients. And then we looked at trigeminal neuralgia. This is very interesting. Many of you never heard of this disease, trigeminal neuralgia. Trigeminal neuralgia in this population, we had 42 patients and 81% got better. 81% got better, which is remarkable. If you know what trigeminal neuralgia, it's a lancinating, sharp pain, usually seen in patients over the age of 55. And trigeminal neuralgia, if you have it, is one of the worst things in the world. Well, guess what? We gave medical marijuana in patients who were not doing well with medication or surgery or neurostimulation, and 81% improved. That also will be published in the near future. I have another question from Cindy. What is the difference between CBD and hemp? Good question. So the hemp is from the plant Cannabis sativa, and it has very low THC, means less than 0.3%, not 3%, 0.3%. So you don't get the buzz, you don't get the munchies of THC. So hemp, CBD could be derived from hemp, or it could be derived from the cannabis plant where there is high THC. Naturally, the plant has high THC, low CBD. So when you have hemp product, you're getting really pure hemp. Now, there's two types of CBD. There's isolate, which is really only CBD, which is what Epidiolex is from GW Pharmaceuticals. Or you can have CBD from hemp that has other cannabinoids, CBG, CBC, CBC. So it's more than there's 60 cannabinoids in the plant at least. And or you can have full spectrum hemp CBD product. What that means is you get terpenes. And let's don't forget terpenes, which gives the smell to the lemon, to the orange, to lavender, is also in the plant. The most common terpene is myrcene. That gives it that smell. So CBD does not smell, THC does not smell, but the terpene myrcene does smell. So I personally feel that terpenes have health benefits. We all know that aromatherapy with lavender, with different aromas are therapeutic, help you sleep, helps anxiety. So a full spectrum CBD product usually has terpenes. All you have to know is which terpene is in it. So hemp, low THC, two types, full spectrum CBD with terpenes, or isolate, which is pure CBD without terpenes. I personally like full spectrum, but some people will like isolate. So that's a very good question, the difference between CBD and hemp. All right. So I'm going to go back to my research, which you can imagine how much work goes into this with our group. So Dr. McVig, who I talked to you about, did also a study. We presented this in Philadelphia as a poster. We had 6 posters, by the way, and we had a symposium that we ran. This looked at post-concussion. So we looked at a population of individuals. I'll tell you how many individuals we looked at. We looked at 103. 103 patients. And we looked at headaches associated with head trauma. Let's call it what it is, concussions. So if you ever had a concussion, you know what that means. 98% of patients have headaches, they have sleep disturbance, memory disturbance, and PTSD-like symptoms after a concussion. We looked at that population, and we saw that that population we treated with medical marijuana. And these are the preliminary results. This hasn't been published. Provided the greatest, 80% of people after we gave medical marijuana slept better. Now, if you don't sleep well, you can't get better. So helping individuals sleep is of the utmost importance. 77% their headaches got much better, and 77% their mood got much better. So here you have this population that's very difficult to treat, post-concussion syndrome. The quality of life scales on these patients improved dramatically. So it was very exciting to see these results. So you can understand why I became a skeptic when I first started this whole journey. And now I'm like, wow, these results are just phenomenal. I mean, I have to tell you, I look forward every day to come to work, to see these patients come to me and tell me their stories. And one day I'll show you some testimonials, which is non-scientific, but how it affects individuals. And at the end of the day, remember, Western New York is one of the places in this country that has an opioid epidemic. An opioid epidemic that has cost the lives of individuals that are in the prime of their life. These are young men and women who are on opioids, who were started on opioids because they had a surgical procedure or because they had a dental procedure or they went to the emergency room and were prescribed opioids for a reason, a good reason. But at the end of the day, it turns into a very addictive drug. And we're having anywhere up to 130 patients or individuals on prescription drugs dying on a daily basis, 130 in this country. Western New York is as you read in the newspapers and the TV, has a major problem on our hands. I personally feel that in my patient population, if I look at all the thousands of patients we've treated, if we look at the ones on opiates, over 50% of them throw their opiates away or decrease the number significantly. So just for that reason, I'm very hopeful that New York State has supported us. And I have to tell you, we tend to be critical of our representatives in government. When it comes to marijuana and medical marijuana, I really have seen leadership qualities coming out of Albany in regard to their medical marijuana commission. They have worked with us. We have met them. They have listened to us. They respect our opinion because we are on the forefront. We're in the trenches, so to speak, and they have worked with us. And I hope to work with them going forward. I hope to make our institute a research center for cannabis that's not only locally known, but world renowned. So that's what we're doing in medical marijuana. That's an update. Now, if you have questions going forward, please do not hesitate to send that to our website, and we'll try to answer those questions for you. Amanda has done a great job by cutting down the waiting time for our patients. And I do think it's important that if you're going to be certified for medical marijuana, that you see somebody who actually does research in that subject and understands the ramifications of different dosages. And it's important that you understand that physicians learn by experience. So when you have over 8,700 patients, I would call that experience. And if you have concerns about dosage of ratios, then I would please consider, we'll be happy to see you. The waiting times are now far less. And we have a really a spectacular group of individuals here, from nurse practitioners, PAs, physicians, and also researchers who will be able to work together. So I thank you for your time. I have 3 minutes left. I don't have any further questions. So with your permission. So Nancy asked, how long is the wait? So the wait is within 2 to 3 weeks, which is not bad because many of you are suffering from chronic disorders. Pardon? It used to be 6 months, and so the wait is reasonable. If you have questions, I tell you what, the population that surprises me that have not been coming to our institute. We see a lot of pain patients. We see a lot of cancer patients, but we don't see a lot of PTSD patients. And I think the reason behind that is many of them are at the VA, and there is a little hesitancy, let's put it nicely, a little hesitancy for federal employees to share cases in regard to medical marijuana because of the fact that it's federally legal. So I can understand that on a personal basis. We have surprisingly low levels of irritable bowel disease or inflammatory bowel disease, mostly because why would you come to a neurologist? But we treat pain, we treat irritable bowel. So we'd be happy to see patients of gastrointestinal side effects if you meet the criteria for inflammatory bowel disease, but do talk it over with your gastroenterologist. And the other population is we have about, to be exact, 63 patients with HIV/AIDS. I think the reason we don't see those patients is because their doctors already certify them and know them better than anybody else. So I think I understand the reason behind that. So once more, thank you for allowing me to sit down and talk to you. I hope I informed you in ways that make you understand that what we have here is something that's very old, 12,000 years, very unique. And the reason we're in the position today is not for medical reasons. It's for political, racial, and economic reasons. And hopefully that will change with time. There's some optimism going forward. And I'm glad that we can probably ride the wave to offering our patients much better therapy. And at the end of the day, when we put our oath for the Hippocratic Oath to become doctors, to improve the quality of life of our patient population. So again, thank you very much. And please do send in your questions. I'm looking forward to seeing you. Bye-bye.